Thanks so much, everybody. It's a real privilege and real honour to be here today, and truly inspiring hearing the likes of Jerry and Martin and all the great work that the IMDA does. So thank you so much. I'm just going to figure... For over the next 20 minutes, I'm going to talk about coordinated and compassionate care. And we all know Charlie Burden, how such an amazing campaigner he has been and truly inspirational person. And I guess I just want to share how Charlie Burden informed us all, informed the nation on the Late Late Show in 2021. And really, I guess one of the things he talked about, and the essence that I think he talked about in this quote, is really about compassionate care. And he said, all I ask is that as a country, as a people, we make sure that we look after everybody who is ill and sick. And really, I think this kind of comes to the essence of what compassionate care is. And it's not just about clinical competence. It's not just about fixing things that are not fixable. It's really recognizing suffering. It's responding with empathy. It's being present with the patient and family. It's actively listening and not being judgmental. And it's honoring dignity to the last. And I think another a quote, I guess, from Maya Angelou, who's a civil rights campaigner in the US and a poet and novelist. And I think this also captures what I think the essence of what compassionate care is. It's, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I guess how does this translate then to compassionate care for people with motor neuron disease? I think it's in relation to a person-centered approach, which is very much understanding what's important to the individual, what's important to them, and supporting patient autonomy. It's all about providing that practical support, that emotional support as it's needed. And we've heard about the great work that the IMDA does. It's also about providing access to equipment and resources, and whether that be information, financial resources. I think it's also about having access to specialist multidisciplinary teams, which we know really improve the outcomes for people living with MND. And it's also about palliative care. And when I talk about palliative care, it's not just about death and dying. I see it more as living, and it's living and maintaining and maximizing quality of life as the illness changes. So we know coordinating care improves survival. And Ireland, I've a lot of my kind of working experience has been in the UK, has been in England. And I would say Ireland has been very much at the forefront of developing and pioneering the best care for people living with MND. And this was a study a number of years ago by Professor Orla Hardiman and the team in Dublin and the academic unit in Trinity. And really what this showed is that it showed that people who were living with MND that were attending a specialist clinic had better outcomes than people who weren't. And they compared people who were attending a clinic in the Republic of Ireland versus those in Northern Ireland. And those had better outcomes. And I guess really the recommendation from this paper was that improve the standard of care of people living with MND. And a culmination of this has been the great work from the IMDA and Professor Hardiman and her team, where the HSE has developed a guideline and recommended a guideline for an agreed pathway for those living with MND in relation to the diagnostic phase, in relation to the specialist MND multidisciplinary team clinics, in relation to hospital-based treatments available, in relation to hospital-based and community services available, and also services available in the community. And many of you will have experienced with these clinics. And in my local hospital in Cork, as well as other hospitals, it's an experience where the patient can access really, really important specialist clinicians and all in one appointment. And I guess my observation is that all of these clinicians are communicating really effectively with each other, and helping to make the best decisions and provide the best support to patients at that moment. And we all know the wonderful kind of IMDA nurses, which I'm looking forward to meeting more later on. They are the cornerstone of this, with the neurology team, the respiratory team, physiotherapy, occupational therapy, speech and language, dietitians, clinical psychology, and social work. And we've heard all of the importance of all of these members in some of our previous talks. And really, I want to give a shout out to the IMDA nurses and how important they are in supporting people living with MND, as well as caregivers in the hospital setting as well as in the community setting, and how important they are in coordinating that care. I'm now going to maybe focus a little bit more on the community side of things, which is where I'm based more, and that would be palliative care, and that would also be GP care, and also public health nurse care. So looking at it in more of a community setting. And when I think about palliative care for MND, I look at it as the active holistic care of people with advanced progressive illness, and it's involving the management of symptoms. That might be helping and supporting spasms or breathlessness or secretions or pain. But it's also providing psychological, spiritual, and social support as it's needed. It's also about helping to support with advanced care planning, and we've heard a little bit about that in the previous talks, of coping with that uncertainty, or attempting to imagine what supports might be needed as the illness changes. But it's also very much a support for family and caregivers, and that encompasses all of our model. And really the aim is, it's about to achieve the best quality of life for patients and their family, help people to live as good as possible, and that's very much the philosophy of what we do. I guess when might we think about this being a right time for me and the rest of the team that I work with to be involved? I guess what I would say is that European guidelines which suggest and recommend that this happen as early as possible. But I would say that this depends on the patient and the caregiver. I've worked a long time in the UK, I've worked more recently in the Isle of Wight, and I guess in that setting, our hospice had done a lot of work over many of years to reduce the stigma of hospice care. Hospice care is not just about death and dying, it's about living. And I guess that stigma in Ireland still is there. But it's also about acceptance. People have to feel that it might be a useful thing and for us to consider. But it also might depend on the local services that might be available. Ireland has a lot of very good palliative care services, but there are differences around the country. I'm very fortunate to work in Cork, and I've got some of my colleagues here today, Orla and Sandy, and we work in a fantastic hospice in Marymount. It was built 15 years ago, so it's a very, very new facility. We have teams just like the the MND nurse who does home visits. We have CNSs, and our team can visit people in the home. We do outpatient physio classes that Sandy and Orla do, where it's fatigue and breathless classes and programs for people living with MND. We also do individual outpatient assessments. We also have a day hospice where we're trying to improve our programs, and that would be for programs for patients and for caregivers and providing support. And we also have the facility, which is the hospice, which is purpose-built rooms. And when I think about kind of referral to palliative care, I guess the top diagram is what we would have very traditionally been about 20, 30 years ago, where it's very much involving us in very much maybe the last week or short months of life. I'm much more familiar with the second diagram. In the Isle of Wight where I worked, actually we had a specialist MND clinics out of the hospice because that was a better environment than the hospital. So we brought the whole specialist MND team to the hospice. So very much People could access our support if needed, but the whole neurology team and everyone operated out of the clinics in the hospice. So that was very much from the time of diagnosis, and our help and support would match that as time changes. Another model is dipping in, dipping out, and that would be on the basis of triggers, where someone might see me, I might see them for a couple of times, and then might not see them for some time, but they might be able to access me again at a later time when they might need me. Just like we've heard about the specialist support that might be available in the hospital, this would be maybe more the community side of things. We've got the IMNDA CNS, who's very much at the forefront as well. We've got the GP, who's the cornerstone and the orchestra within the community. We've got the public health nurse. We've got the community physio and OT. But we also have the community palliative care CNS. We also have a palliative care doctor like me in the background. We have our day hospice team, Orla, Sandy, our physio team, our occupational therapists, nurses, doctors, and we also have social worker and spiritual care. So we are very much in MDT as well, supporting the individual and their family as best we can. I guess now I'd like to share with you some research, and this is research that has had the involvement of patients and caregivers, and it's just sharing something that came out over the last couple of years, and essentially this was pooling all of a number of research studies together. So it looked at qualitative research studies, which is interviews with patients and interviews with caregivers, and it looked at all of those studies over a number of years, and pooled all of that data together. And there was 41 studies in this paper, and they pooled all of that data together to come up with recommendations. And I've just selected two to kind of share with you. And one of the recommendations was the need to think ahead and prepare for the next stage of the disease and plan for what supports or interventions may be needed. And I guess that might be, we've talked about the uncertainty of the illness, but there also was an element of maybe anticipating what could happen and planning ahead. But also there was the recommendation of supporting healthcare professionals to introduce advanced care planning in the disease and at points of deterioration. So to help clinicians and healthcare professionals like me to have those conversations and do that sensitively. Another study which was specifically about advanced care planning looked at interviewing caregivers and looked at their perspectives. And this was a number of years ago as well. But it looked at the recommendation out of that is the timing of introducing needs to be approached very sensitively. Everyone's an individual. Everyone is different in how they approach things, and that needs to be respected. And how we do this needs to be on a very much on an individual basis. And we offer conversations rather than forced conversations. But really some of the benefits of advanced care planning that was shared was that having these conversations and sharing that can actually empower patients and families. Having these, using these tools can actually increase that connection and communication within families. It can help to have conversations that people are maybe reluctant to have. But ultimately, it can also help with clearer decision-making at the end of life. And really, it's about kind of supporting patient autonomy. So how does it work in practice? Well, I would say it's clinicians may offer and explore what is important to someone, what are their goals of care, what matters to them. And it's about thinking about what are the interventions that might be right for you, and in I guess clearly in providing as much information as possible in a timely way, and thinking about how that might be. It's also thinking about where someone wants to be as they if they're unwell, or how they want to be cared for. And really what I would say is that these are not conversations that happen on a one-off. They're things that happen intermittently as time progresses, and we're re-exploring goals of care and what matters to people as the illness changes, because things change over time and people's understanding and their preferences and their goals may change over time. But what we would recommend is that it's sometimes better to plan ahead and avoid crisis planning, because these conversations are a lot easier to have when at a time where we're all able to think about that and in a less stressed way as possible. But really what I would say is the aim of the whole care team is to support that person-centered care, really supporting what matters most to someone and what is important to them, and supporting autonomy. If any of you are interested, advanced care plans are very common in the UK. They're less common over here. But if anyone is interested in what these might be and what they are, there are these available on the Irish Hospice website. And this just gives a kind of a pointer of what that might be and what I'm talking about if people are interested. And I guess finally, the last thing I would like to say is I'd like to finish with Charlie. So Charlie, was an amazing campaigner, and we've heard about all the great work he's done raising awareness and campaigning for fundraising. And I guess really all I'm sharing this comment from Charlie is how he's normalised, advanced care planning, I would say, in this comment. So Charlie, this is a couple of years later, he's been introduced to the Wicklow Community Palliative Care team, and he said, "I want to be very honest. When my time comes, I want to die at home with my family around my bed. Coming to the end of my life, the role that the hospice plays has been revealed to me." So I just want to share this, that this is Charlie again, sharing his experience and promoting and normalising things. So thank you so much indeed.